Good morning. Hi, how are you? Wail Mohammed is my name. I'm a consultant neurosurgeon here in Cork University Hospital. It gives me great pleasure to chair the parallel session number 2 for the second day and charter day RCSI 2022. We have a good few speakers from the 3 Irish units, Belfast, Dublin and Cork, with various subjects to cover, and I hope everybody will enjoy this session today. It also gives me a huge pleasure to introduce the first speaker for the first session, Mr. Tom Flannery. Mr. Tom Flannery is a consultant neurosurgeon in Belfast. He has a special interest in oncology, neuro-oncology, and in stereotactic radiosurgery. He did his fellowship in California and Pittsburgh, when he has a huge amount of collaboration and research done in medical oncology. Not surprisingly, his talk today is going to be on the Belfast 10-year experience and outcome in low-grade glioma between 2010 and 2020. Tom, the floor is yours.
Thanks, Mahal. I'll just share my slides here. So good morning, everyone. Thanks for the opportunity to outline my own experience, I suppose, rather than the units. But so it's an overview of the surgical outcomes and epilepsy and survival outcomes over this period. I'll talk a wee bit about low-grade glioma pathology as well, and some reflections and learning for the next 10 years, hopefully. As everybody is probably aware, low-grade gliomas are generally slow-growing progressive tumours that grow and infiltrate the adjacent normal brain. It comprises 2 histological categories, astrocytomas and oligodendrogliomas. They tend to be most common in young adults, and the median overall survival varies a little bit, but it's generally shorter for astrocytomas compared to oligodendrogliomas. And generally speaking, these tumours will inevitably progress to a more malignant category of tumours. So the primary role of the surgeon is to try and get maximal safe resection to delay the time to malignant transformation. The classification of low-grade gliomas has changed a little bit over the years. We're currently on the 5th edition of the World Health Organization classification, but in the last 2 classifications, the diagnosis has become more integrated based on tissue histological, immunohistochemical and molecular markers. So currently, by definition, an astrocytoma is IDH mutant, oligodendroglioma is IDH mutant and 1p19q co-deleted, and the IDH wild-type tumours are now categorised under glioblastoma. So this study focuses on the diffuse adult low-grade gliomas in my own sort of personal experience over a 12-year period. Pignati published a paper in 2002 in Journal of Clinical Oncology based looking at prognostic markers in low-grade gliomas, and basically the study showed that there was 5 criteria, 5 prognostic features that conferred a worse outcome for patients, and these markers were based on clinical, imaging and histological features. So patients with an astrocytoma was given 1 score, 1 mark. Patients over the age of 40 were given another mark. Maximum tumour diameter, if that was greater than 6 centimetres, another mark was given. If the tumour crossed the midline, again, another poor prognostic feature, and the presence of a preoperative neurological deficit. So each of those criteria was given 1 mark, and then a score was derived from this, and this is basically the Pignati score. And this indicated that patients with fewer poor prognostic factors fitted into the low risk group, 0 to 2, and those with more fitted into the high risk group, and these had a worse prognosis and a worse outcome. And this study was validated by Daniels et al. In 10 years later, using various North American trial, which looked at the timing of radiotherapy and found that the low risk group had a better prognosis, better overall survival of 10.8 years versus 3.9 years, and progression-free survival. Now, additionally, additional molecular markers have come into play, and we now know that IDH wild-type tumours now behave more like glioblastomas. There's other mutations such as the cell cycle regulators mutations are associated with poor outcome, and 1p19q co-deletion is not only a good prognostic marker, but it's a predictor for response to chemotherapy. So this was one of the things that I used in this study, retrospective study, to try and characterize the patients that I've operated on. Another important study, which surgical colleagues are probably familiar with, was a flawed study, but it was very important and sort of slightly game-changing study in its own way, because it made European centres become a bit more proactive and advocated a maximal safe resection, including tumours in eloquent areas. So it basically compared the outcomes of 2 Norwegian centres that were matched demographically, but with different surgical philosophies. One that was more a biopsy approach, and the other was a more maximal safe resection approach. And the difference was significant in terms of median survival and time to malignant transformation was hypothesized to be a key factor, a key benefit of maximal safe resection. You're delaying time to malignant transformation. Another key thing is, and it's important just for this, my own study, is because in 2010, essentially the approach from our oncology colleagues was a more watchful wait approach and radiotherapy. The earlier study from the RTOG 9802 and the comparable European study, they didn't indicate a significant survival advantage by adding chemotherapy. But in 2016, Buckner et al. In their longer term analysis showed that addition of chemotherapy did confer a survival benefit, not only in the co-deleted oligodendroglioma glioma cohort, but also in the astrocytoma cohort. So post 2016, the standard of care for high risk, low grade glioma patients in Belfast is that patients get radiotherapy followed by PCV chemotherapy. So there's a bit of a change in philosophy from the first 5 years to the second 5 years of this cohort. The other thing I want to look at was the incidence of epilepsy and the control of epilepsy. How did epilepsy respond to treatment? Because there was a Cochrane review which looked at the timing of radiotherapy in low-grade gliomas. And as part of that study, part of that review, they found that seizures were improved in the patients who were treated with early post-operative radiotherapy compared to those patients that were monitored. So there's the incidence, the seizures at 1 year were 25% in the early radiated group compared to 41%. So people who underwent early radiation had better seizure control at 1 year than people who underwent delayed radiation. So the aims, as I say, I've already outlined, looking at the surgical outcomes, the survival outcomes, and the epilepsy outcomes of this patient cohort. All patients were discussed at our regional MDM and seen at our rapid access new oncology clinic. All patients underwent anatomical imaging, including a FLAIR study, and functional imaging such as fMRI, tractography, perfusion, spectroscopy as indicated. Wave craniotomy was performed on patients who had eloquent tumours, and the standard neuronavigation techniques with microscope integration, heads-up display, intraoperative ultrasound, and post-operative MRI for extensive resection evaluation. Just a few example slides. This is your FLAIR periinsular tumour. The left two indicate the preoperative and the postoperative, on the right indicating resection error. Functional MRI useful for cortical mapping to indicate areas of speech activation that will influence trajectory, site of entry for tumor resection. Spectroscopy, in this case, indicating a more malignant peak. It does influence your approach surgically. And this study, this patient had FLAIR, spectroscopy, and perfusion. In this case, there was no difference between the hemispheres in terms of perfusion or increased blood flow. So this was a low grade and confirmed histologically as such. Surgical tractography, very helpful for deciding how deep to go. And again, this is a good illustration that although there's tumor infiltration in the deep white matter tracts, it does indicate where it's safe to resect without causing harm. And you're all familiar with neuronavigation. In our case, we use BrainLab, and this is an example of the provided by the company of your projected tumor volume. The solid line is the area of the tumor in focus, and the dotted line is the extent of the tumor, and the fiber tracks indicate the eloquence of the area of the tumor, and intraoperative ultrasound is useful for validation. Sometimes we did a two-stage procedure in cases where they're eloquently situated to try and maximize extent of resection. So summarize, so I had 63 patients with a median follow-up of 5 years, ranging from 1 to 15 years. 13 patients are deceased and 79% are still alive. Male-female ratio, you can see, mean age mostly 39 in the young adult range. Frontal, temporal, insular, parietal. This study excluded brainstem gliomas. And all patients underwent preoperative flare except one patient who had CT because of his claustrophobia. Biopsy was performed in 5 patients. The remaining patients underwent image-guided craniotomy and attempted maximal safe resection. Based on the post-operative MRI, less than 80% resection was achieved in 25 patients, and then subtotal and gross total formed the remainder. Awake craniotomy was performed in a quarter of the patients. 5 patients had a new permanent neurological deficit post-operatively, about 8% or so. The number of surgical procedures, so all patients, as I say, had histological confirmation of their diagnosis. 37 were astrocytomas, 26 oligodendrogliomas. 19 patients of the 63 underwent multiple procedures. 6 patients demonstrated progression to a grade 3 tumor and 1 patient to a grade 4 tumor. Thankfully, there was no wound healing problems in these multiply operated patients. In terms of the oncological treatment, 18 patients have not yet had oncological treatment. They've had watchful surveillance because the tumor has been gross totally resected, or by patient choice, or the oncologist felt the patient was too frail for oncological treatment. 18 patients had adjuvant treatment fairly soon after their surgery, and then 27 patients underwent oncological treatment on imaging progression. And these tend to be the pre-2016 cohort. And generally, it's radiotherapy followed by chemotherapy, PCV, and treatment on relapse in terms of second-line chemo with temozolomide, or re-challenging with PCV, or in a few cases, re-irradiation. Survival analysis. So basically, the sort of main median estimate of the overall survival of the entire cohort is about 13 years. Main estimate is 13. As expected, histology was a significant prognostic factor. This is the Kaplan-Meier for the oligo cohort versus the astrocytoma, and this was significant with p-value of 0.15 using log rank score. Estimated mean survival difference was 13 for the oligo group, 9 for the astrocytoma group. When we looked at our Pignati score, this is a breakdown of those patients with no poor prognostic Pignati criteria, with 1, 2, 3, 4, etc. So when we followed the previous publications and arbitrarily split our patients into the low risk category and a high risk category, there was a significant difference, albeit given the small numbers of the high risk category, and again a significant difference. Mean survival 4 years in the poor group, in the high risk group, versus 6 in the low risk category. Extent of resection, so we pooled all the gross total resection and those subtotal resected, i.e. those patients with more than 80% tumor resection versus those with less than 80% tumor resection. And again, there was a survival difference, not quite significant in this occasion, and the survival was of the order of 2 years, 2.5 years. Lumping these all together in an attempt, given small numbers, it's just a sort of preliminary data, I suppose. And the one that sort of approached significance was, as you'd expect, the histological category. The others did not, weren't really associated with any significance. And then wrapping up shortly, the use of anti-epileptic drugs. Seizures was the primary mode of primary presentation in 49 patients, i.e. 78%. A further 5 patients developed seizures post-operatively at some stage in their illness. So 86% had seizures at some point in their illness. The common anti-epileptic drugs prescribed included Keppra, lamotrigine, Tegretol, Epilim. Most patients had seizures controlled with a single anti-epileptic drug, although 18 patients required 2 or more anti-epileptic drugs to optimize seizure control. As I said, there was about 9 patients who didn't have any seizures at any stage. on seizures post-treatment. So this includes surgery, radiotherapy, etc. So it's a fairly overall feel for how the seizures behave following treatment. The seizure control improved during the course of treatment in 34 patients, while an additional 3 patients were able to come off their anti-epileptic drugs. 18 patients had ongoing or worse seizure control requiring additional anti-epileptic drugs. A few flaws of the study, because there was a small number, about 8 patients who had surgery. Most patients had surgery shortly after their initial imaging diagnosis. There was about 8 patients who had tumours that were watched initially for a few years by my colleagues before they were referred on for awake surgery. So they had been on the go for a few years before they actually underwent surgery. So I've used, just for the purpose of standardization, the survival is basically the time from imaging diagnosis to time of death or last follow-up. It'd be quite interesting to include other factors in the future, the quality of life metrics, which are becoming very much in vogue. And I think we might need to do some further ad hoc analysis comparing the survival of the pre and post 2016 cohort when the oncological management did change. And hopefully we'll have some more mature data in 10 years' time if I'm still around. So I think that's my talk given. Sorry, it was a bit of a rush, but hopefully if you have any questions now, I can take a question or so.
Thanks, Tom. That was very comprehensive, very comprehensive talk. An interesting talk about low-grade glioma and your experience in Belfast. I don't see any questions on the, let me just double check on the screen here. But while we're waiting, if there's any questions, can I just ask you, do you have any standard advice for anti-epileptic for those patients post-op? Do you keep them on anti-epileptic for a certain period of time?
So I think I haven't included it in the talk, but now I've got a more standardized epileptology approach. We have a designated tumor epileptologist, and we basically, Mohammed, just refer all our patients to him. And Michael Kenny's the neurologist, and we basically delegate everything to Michael in terms of follow-up. So this is something that we're looking at, and we're hoping to do a bit more sort of research in this area, and maybe link in with 1 or 2 of the guys from Trinity as well, and sort of the guys from the Cancer Research Centre. So I'd have to defer question to my neurology colleague, but I think that from what I've seen, most patients do tend to stay on medication once they're counselled about the risks of breakthrough seizures, the impact on their driving, etc. Most of them, from my reading of the charts and medical information I've had, they generally tend to stay on the medication and have good control, with a few exceptions.
Thank you. And one more follow-up question. The Benatti score, you know, the way if you score them today, and for example, there's going to be very little variation, particularly the age. Do you score them again if they cross the 40, and then do you give them a different score, or do you just stick to the initial score?
I think it's the age of diagnosis.
Okay.
Age of diagnosis. So it's a pre-operative, but then obviously once they have their histological analysis, that gives you the final score, I suppose.
Perfect, thank you. I'm just waiting on the technical support and if there's any questions, but I can't see any so far. Yeah, I think we're good.
Yes, you've no questions from the audience.
I think we're good. I think we might just move on since we are going to capitalize on this time gain. Thanks a lot, Tom, for very comprehensive. And we'll chat soon. Thanks a lot. Our next talk is from Dublin, from Beaumont. We have Mr. Michael Amoo, who's going to talk to us about the Dublin chronic subdural hematoma score, which is a score to predict the recurrence of chronic subdural hematoma. Michael.
Thank you. My name is Michael. I'm one of the trainees in Beaumont. We're just going to be presenting our work we did on chronic subdural hematoma and trying to predict the patients who are at highest risk of recurrence. So chronic subdural hematoma has been...
Sorry to interrupt you, Michael. Your audio is a little bit quiet.
Oh, okay. Sorry. Is that better?
Yes, that's a little bit better. Sorry, it's less comfortable for you.
No problem. So chronic subdural hematoma has been described as, I suppose, the hip fracture of neurosurgery. The incidence is increasing as the population is getting older. There's more widespread use of antithrombotic agents. There's also kind of the ongoing debate as to whether chronic subdural hematoma is as a result of transformation of acute subdural, with a study from the UK demonstrating that up to 50% of patients develop the so-called de novo chronic subdural hemorrhage. About 40% of patients with chronic subdural don't recall a history of trauma, although it has been shown that even subtle things such as coughing and straining could sometimes cause a subdural hemorrhage in these patients. There are a number of management options. Most patients are managed conservatively. There's pharmacological options. One of the kind of higher profile studies in the last year or so is the DEX chronic subdural hemorrhage study, which doesn't really support the use of dexamethasone for a majority of patients with chronic subdurals. Surgery remains the gold standard, the mainstay, and there are a number of techniques to be used for surgical evacuation. And middle meningeal artery embolization is starting to gain popularity. Recurrence remains a significant burden, both at individual level as well as resource constraints on the healthcare system. There's increased mortality as well as the perioperative morbidity that's associated with reoperation. So how do we identify patients who are at risk of developing a recurrence? We know from the Toscan trial that routinely scanning people or following them up with scans over a period of time to identify reaccumulation actually doesn't really improve outcomes. It just imposes more cost on the healthcare system. And if we could develop a system whereby before their initial operation we could identify which patients are at risk of having a recurrence, we could offer them adjuvant or neoadjuvant treatments such as embolization or some of the medical pharmacological agents. So the radiological appearance of chronic subdural hematoma on the preoperative CT scan has been shown to somewhat predict the risk of recurrence. And this is because, especially with the mixed density chronic subdurals, it reflects the chronic pathophysiology of expansion of chronic subdural as well as the risk of recurrence. A score that's out there but's not really widely used is the Oslo score that essentially stratifies patients to their risk of recurrence based on preoperative and postoperative CT findings. They break down the appearance into these 8 groups as seen on the left, and 7 groups as seen on the left here, as well as some parameters such as preoperative volume and residual capacity, the amount of air on the scan after the operation has been performed, as well as the presence of seizures. One of the criticisms of this is the inter-rater kind of reliability of this, kind of breaking these down into 7 different groups. There's very little difference, between, I suppose, between observers, for example, between B and C, the isodense and the hypodense, or even how one can, tell the difference between what's termed laminar and what's called separated. The other criticism is also the fact that you need to get a post-op CT on these patients, and you need to use parameters from that post-op CT. So the question we asked ourselves is, can we develop a score that's based on one CT, the pre-op CT? So we looked back at a prospectively collected data and looked at a 2-year period, 2018 and 2019. I think the summary of this page is that we did some fancy statistics. Essentially, the bottom line is that the stats that was performed was more weighted towards sensitivity. What we wanted the score to do is to identify with a high sensitivity which patients will have recurrence. There's really not a lot to be lost if we identify patients who do not have recurrence as having a high risk of recurrence. So just in summary, we did some misclassification costs that had 3 times weighting towards sensitivity. And then we looked at certain variables, continuous and categorical variables. We performed univariate regressions on these. The ones that were statistically significant went on to be included into a Lasso regression, which is a type of regression that's used in artificial intelligence and big data. And essentially, the advantage of it when compared to logistic regression is that it does the regression in a stepwise fashion. It starts with a variable. If that variable is significant, it adds on another variable in a layer, does them separately. And the variables that were statistically significant then went into a global model where they were given certain coefficients based on how much they contribute to risk of recurrence. So we included 142 patients in the analysis, and in keeping with the international literature, the recurrence rate was in about a quarter of patients. And we defined recurrence as symptomatic reaccumulation of chronic subdural hematoma radiologically that required intervention within a 3-month period. So the variables that made the final analysis were patients with age over the age of 65. We found them to have an odds ratio of 5.19, hematoma thickness greater than 12 millimeters, as well as the presence of bilateral hematoma. And we came up with this score. Now we added the radiological appearance based on a priori hypothesis. So even though the appearance wasn't significant in our cohort, there's multiple studies out there, including a recent meta-analysis that showed that patients with a mixed density hematoma tends to have an increased risk of recurrence. So we included that in our model, and this is allowed in model building. So the score we came up with is a 4 segment, whereby patients with a hematoma thickness greater than 12 score point of 1, point of 2, age greater than 65 score point of 2, bilateral hematoma have a score of 1, and the hyperdense group have a score of 1, with the highest score possible being 6. We then went back and tried to validate the score and test its strength, and we certainly saw a significant linear association with patients who have a score of 3 to 6 having a higher risk of recurrence when compared to patients with the lower score. You can see with the p-value here. So putting this into, I suppose, the context of, you know, the 75-year-old farmer.
You have 2 minutes, Michael.
No problem. So I suppose putting it into the context of a 75-year-old farmer from Galway who, you know, has bilateral chronic subdurals, you know, this gentleman would have a score of 6. You know, even with a good post-op scan, there was still the debate as to when is the ideal time to stop this patient's aspirin. And unfortunately, he developed a recurrence. His aspirin was still on hold, developed a PCA territory infarct, which thankfully only left him with a visual field deficit that he was able to live with. He subsequently came across for an MMA embolization in Beaumont, and we were able to restart him on his aspirin. If we had used this score preoperatively, we would have been able to, I suppose, identify him as a high risk of recurrence, maybe offer him MMA embolization either preoperatively or postoperatively, and be able to restart him on his aspirin sooner. So this is where we hope that the score will be useful in, I suppose, identifying patients who would benefit from adjuvant treatment. So we're currently designing a prospective validation study that we hope the unit in Belfast and Cork will be a part of, as well as a few UK centres. So we'll be in touch very soon. Thank you very much for your attention.
Thanks, Michael. This is very interesting, and I assume there's a huge amount of work that was put into it. Be very keen actually to participate in any future projects to kind of validate this. I can assure you from now we're gonna have a huge difficulty convincing the guys here in Cork to use Dublin as a name on the score, but we'll find some sort of compromise. We're just waiting for a few questions. If there's any questions on the panel chat box, you can guys type them. So just for the general audience here, it's a 6-point score, and the higher you get is the higher chance you're going to have recurrence.
Exactly.
And the lower is the obviously the best for the patient.
Yeah.
Okay, I'm still waiting. There's no questions yet. Do you have any more remarks or comment that you want to add?
Not really. I mean, we hope to get the validation study because one of the flaws of kind of what we've done is that we've validated based on, you know, pretty much the same data. So, you know, that's one of the criticisms of what we've done. But certainly, if we have you know, prospective data that we can use to validate it and you know, potentially modify it, you know, there are factors that have been shown to affect recurrence, such as the use of drains, for example. But in our cohort, about 90% of patients had drains. So when you have, you know, we have a center where pretty much everybody gets drains, it's you know, you're probably not going to see a statistically significant difference there. So it'll be interesting to see when we do the prospective validation if there's any other factors that we can add to the score. Well, a modified Dublin score, or maybe the Dublin Cork score.
Thank you. Just going to invite the other speakers if there's anybody from the panelists who wants to ask questions, given that we have another 5 minutes. Okay, Michael, I think you're off the hook. Thank you very much. And I'm going to introduce the next speaker for this next session, which is Mr. Vincent Healy. He's one of our SPRs here in Cork. He's nevertheless still is he's missing Dublin so much, so he's going to talk about surgical management of intramedullary spinal core tumors in Beaumont. And I'm going to leave him for 15 minutes to tell us about this project. Vincent, the floor is yours.
that sharing the PowerPoint? I can't see my PowerPoint.
Are you able to share your screen?
I'm just trying to share that now. It's not working.
So when you click the green share screen button, you should be given a pop-up box which says which window would you like to share?
Yeah, so for some privacy issues, it's saying.
I see.
Might be an idea if Cathal is available to do his. I think he's next, and maybe we jump to his, and I can just change the privacy settings and come back to me.
Okay.
Right.
Okay. So we're going to just swap sessions now. We're going to move to the following session, which is actually supposed to be presented by Professor Michael O'Sullivan, consultant neurosurgeon and the lead neurosurgeon here in Cork University Hospital. Michael was supposed to talk to us about the management of vestibular schwannoma in Cork. Actually, matter of fact, he is doing one right now as we speak. So he's delegated our SHO, Cathal Lee, to talk about vestibular schwannoma management here in Cork University Hospital. Cathal.
Perfect. Thank you very much. As Mr. Mohammed was saying, presenting this on behalf of Professor O'Sullivan, has put this talk together with one of the medical students who is working with us at the moment, Oleksandra Kaskun. He presented a few cases at the end. So we're going to give a very brief overview of vestibular schwannomas in general. So these arise from our Schwann cells, which are a feature of a peripheral nervous system, exclusively so, not within the central nervous system. We have multiple myelin sheaths per axon, and these Schwann cells act as a functional support to these and improve the saltatory conduction. And these are separated by nodes around here, which improve on these impulses. As you can see, histopathologically, these darker purple cells and the separation, you've got multiple along each axon. The type of disease processes you can have from these type of cells. You've got the demyelination arm, which include things like Guillain-Barré, infector-mediated process, Charcot-Marie-Tooth, something genetically predisposed, and things like diabetic neuropathy. We're not too interested in those for today. We're more concerned about the neoplastic arm of pathophysiology for Schwann cells, so things like neurofibromas. You have acoustic neuromas or vestibular schwannomas, which are inherently benign, and anything malignant of the type are classed together as a malignant peripheral nerve sheath tumor, or MPNST, which we're not going to speak about today. Acoustic neuromas, they make up a small amount of intracranial tumors. They're typically sporadic and unilateral, and sporadic cases usually present slightly in a slightly older population, between the 5th and 6th decade of life, where there are some genetic predispositions, including the neurofibromatosis families. These present typically a little earlier. However, while they are a rare tumor, they make up 90% of the tumors within the CP angle. Historically, they were considered as a tumorous mass, which arrived off of the auditory nerves, which gave them the name as acoustic neuroma. There were improved investigations over time. It's felt that this nerve had a balance component. It was renamed to the vestibular cochlear nerve, and that this tumors actually result from the Schwann cells from the vestibular component. So more technically speaking, vestibular schwannoma is the more correct term. However, within the literature, you'd see both used interchangeably. And then these tumors arrive in the cerebellopontine angle. So this is a region of the brain between the cerebellum and the brainstem. Its boundaries include the cerebellum posteriorly, the tentorium anteriorly, and the pyramids, the posterior aspect of the brainstem anteriorly. It contains very important structures, cranial nerves 5, 7, and 8, including the lower aspect of the lower nerves 9 and 11, and important vascular supply. So within the CPA, as I was saying, acoustic neuromas or vestibular schwannomas account for the vast majority of these space-occupying lesions. However, they're not the only thing within the differential. It's important to keep in mind that meningiomas make up approximately 5% of lesions in this area, but you also have a wider diagnosis of metastasis You can have schwannomas of other cranial nerve cells, or you can have aneurysms, or even some tumors arising from the bone itself. So for example, here we have 3 separate disease processes within the CP angle. On the furthest left, we have what turned out to be a trigeminal schwannoma, which is extended into the middle fossa. In the middle, we have an arachnoid cyst, and on the right, we have a meningioma. It's important to have a very clear diagnosis, as this is, it obviously aids in your option or your management options and what you would like to do for these patients. What you do find in vestibular schwannomas, so MRI is the imaging of choice. These are hyper intense in T2, and they avidly enhance with contrast. They're often not homogeneous. They often have a cystic component. And when you look at the image itself, as the tumor arrives from the internal auditory meatus, it takes on an ice cream cone type appearance. And when you compare the meatus to the unaffected side, this is often widened. Just briefly, as I mentioned earlier, there are some genetic predispositions, and most commonly will be the neurofibromatosis family. Type 1 being more common, however, you can often see more of these lesions in type 2. What's important to note, and we'll discuss a case later on, is that both of these conditions also make you more likely to have meningiomas, and it's important to have a very clear diagnosis before operating. So vestibular schwannomas or acute schwannomas, these typically present very insidiously. Patients have some hearing loss that on audiometry is typically sensorineural, and they have tinnitus. And these can be very slow growing processes and could be may not be noticed for a number of years. As these tumors get a bit larger, you can have some vestibular dysfunction, or at the very extreme end, if you have complete effacement of the fourth ventricle, you could present as an acute hydrocephalus. The natural history is that these are slow growing tumors. Typically their volume only increases by 1 millimeter or less a year. So historically, these are things you could, in a small tumor, you could watch and wait and see how they progress. It's important to note that there is a small subsection that can grow by greater than 1 centimeter a year, and they're very difficult to predict. And the extrameatal component of the tumor typically grows quicker than the intrameatal. It's just kind of accept the wisdom that the larger the tumor is on presentation, the more likely you are to run into issues with these, and the more likely they are to grow in size. So what options we have for these type of tumors? So essentially 3 accepted surgical techniques. You have a middle fossa approach, a trans-labyrinthine approach, and a retrosigmoid approach. Then non-surgically, you have stereotactic radiosurgery, which can be used for very small lesions, or can be used as adjuvant treatment post-surgically. This is an arm that we use very frequently here in Cork. We'd often, the vast majority of our patients do not undergo surgery. They go straight for observation or SRS if they're less than 2 or 3 centimeters. And then all of our post-op patients are considered for radiosurgery. So trans-labyrinthine approach, this and the middle fossa were 2 approaches pioneered by Dr. House in Los Angeles and California in the 1960s. This is a post-auricular incision and involves a complete mastodectomy and a labyrinthectomy. This is a good type of surgery for patients who already have hearing impairment, as there's very little chance of hearing preservation. It has some benefits in that it does provide some excellent exposure. However, they do have an increased risk of CSF leak, and you do need to have a specialist ENT surgeon who's experienced with dealing with these type of surgeries as a combined case. Our other type of approach, again developed by Dr. House, is a middle fossa approach. This time the incision is pre-auricular. It has some advantages over other cases in that you have very good exposure to the IAM. However, you don't have quite as good exposure to the CP angle in itself. You don't have to have retraction in cerebellum, which helps reduce the risk of those. However, as a standoff, you're now retracting temporal lobe, so you're exchanging one risk for the other. Now, what we do here in CUH, what appears to be most common throughout the literature, would be the retrosigmoid or suboccipital approach. It's pioneered in the early 1900s and has been evolved over time since. This is a post, and over the last number of decades, you can include partial mastectomy to have a hybrid approach between the and a trans-lab approach. These give excellent exposure to the CP angle. There's no limitation to the tumor size that you can approach with this. With this type of approach, often these tumors you can organize are an external ventricular drain and drain off some CSF just as you're completing the approach. That is what we typically do here in CUH. So I was kind of comparing the three approaches. They all have their pros and cons. They all give good exposure for specific types of tumor. So the main thing to keep in mind is that the middle fossa and retrosigmoid approach can be used for hearing preservation, whereas the trans-labyrinthine approach, there's very little chance of hearing preservation. So if someone already has a very poor audiogram, you might be tempted to use that. However, you would need to have a specialist ENT surgeon with you. And then the other option would be stereotactic radiosurgery, which is a form of radiotherapy. They are very good for very small lesions, and the smaller the lesion that is treated, the less likely you are to have any complications such as hearing loss. An awful lot of our patients don't see surgery, they go straight for SRS, and after surgery they'd all be considered for SRS. Now actually not a huge amount to proceed to it, but it's always considered. So the complications of these types of surgeries, the damage to local structures, the two are really going to be worried about are hearing loss and facial nerve injury. As I said, most patients present with hearing loss, but facial nerve injury is something that can be quite debilitating. Certainly you can have types of CSF leak, as I said, is more common in the trans-labyrinthine approach. And then for all types of surgery, you have risks of meningitis and bleeding. So as I said, the facial nerve injury, that's probably the most important thing, most common complication of these types of surgeries. And it has a number of scales. The most common would be the House-Brackman grading system, which ranges from 1 to 6, 1 being normal, 6 being complete paralysis. Typically across the literature, 1 and 2 is considered a good outcome, and 3 onwards would be considered a poor outcome. But the main taking point is that the difference between 3 and 4 is a very important distinction. A grade 3 can close their eye, whereas a grade 4 to get incomplete eye closure and certainly needs to be followed up both by ENT and ophthalmology afterwards. And this here is kind of a progression of the House-Brackman grades. You can see left are good responses, on the right we're having very, very clear deficits both statically and non-dynamic movement. So the main question that appears to pop up over decades is whether this type of specialized surgery should be completed in a very centralized location, or would it be operated on in a regional base. There's been very good papers across Europe for a centralized model. Very good papers coming out of Denmark that exclusively do it all in one service. Whereas closer to home in the UK, they have more regional based. At the SPINAL meeting 3 weeks ago, at the skull base talk, which was keynoted by Mr. McFarland, who presented a talk on 30 years of acoustic neuroma surgery. When he was dealing with that question, he felt that it all comes down to your complications and your outcomes. If your outcomes are comparable, that you can absolutely justify doing it on a regional base. That's the question we kind of had for ourselves. Do our complication rates stand up with our contemporaries? And based off of that, can we justify continuing the service here as a small or low yield service? So within the last 5 years, there have been 2 pretty big papers that include over 600, over 300 papers. They've been looked at just since the turn of the millennium, which is comparable to ours. One thing why I picked these 2 papers is that they exclusively use the retrosigmoid approach, which is what we do here, and they're both single center. Main important differentiation is both of these papers, they very much aim for a gross total resection, which isn't what we do here in CUH. And their tumors are typically slightly larger. Their average tumor size is just over 4 centimeters. Ours is just below 4 centimeters. We also looked at this very well quoted paper by Mr. Sami. Again, single center, very large tumor load. Considered nearly a gold standard paper. It had just less than 1 in 10 anatomically noticed facial nerve injuries intraoperatively, with very decent post-op facial nerve function. Nearly 3/4 had what we consider good function, which is, as I was saying, is the House-Brackman 1 or 2. Whereas in these two other papers, which are more recent than Mr. Sami's work, this is a paper that included 300 cases. They grouped their facial nerve function as 3 to 6 as being intermediate to poor, and was present in just under half of their cases. They also had 1 in 10 was noticed to have an intraoperatively noticed facial nerve injury. They also had a number of other transient palsies. They had a very small mortality rate. Whereas at the slightly larger paper, over 600 patients, they also had a very similar facial nerve function. Just under 1 in 10 had perioperatively noticed facial nerve injury, and postoperatively had very similar facial nerve function at 44% compared to 45% in the previous one. Interestingly, they also had just under 3% required permanent CSF diversion. So we wanted to see how our numbers would rank with these. So looking at our CSDH service, we look at from the neuro-oncology MD, and we then pulled the histopathology reports of these schwannomas, excluded other cranial nerve for the patients who were listed as a schwannoma. 42 of these, or 41 of these was spinal schwannomas, and one was a trigeminal schwannoma. These were excluded, which left us with 43 unilateral vestibular schwannoma surgeries. Of these, we had one case of NF1. We pulled the operative notes and the medical charts for these patients. Let's say we had 43 patients, 1 NF1. Our service operated 100% as a retrosigmoid approach. We had ENT involvement with just under half of these cases. Our average size of lesion was 3.5 centimeters. And post-operatively, all of these cases get discussed at our fortnightly neuro-oncology MDT. As I said, our major difference between some of those other papers is that we operate on a hybrid model where we don't particularly aim for gross total resection. We aim for a near total resection with follow-up surveillance plus or minus SRS, depending on the post-op scan and the feeling at the neuro-oncology MDT. What was determined as the near total and subtotal resection was based off of what the consultant felt intraoperatively and post-operatively. So in terms of our complications, we had 2 cases of an intraoperatively noted facial nerve injury, which is 4.5%. And post-operatively, nearly three quarters had completely preserved facial nerve function. Out of those who had facial nerve deficits, 13% had full paralysis and Klaus-Bracken grade 6, and required further treatment with our ophthalmology and ENT colleagues. And just under 5% of our patients had a pseudomeningocele, and just under 5% had a transient hydrocephalus. Only one of these required permanent CSF diversion. And out of our 43 patients, only 1 case required further surgery, which we will talk about as a case report at the end. And interestingly, we had 1 patient had a transient wrist drop associated with the positioning intraoperatively. As I said, so out of these 2 cases, 1 patient required permanent CSF diversion in the form of the LP shunt, and we had 0 mortality. As I'm showing here, most of our patients had excellent facial nerve outcome, and indeed 2 of our patients who had a poor outcome subsequently improved over time. So I suppose when we compare, we felt we had favorable comparisons, both with older gold standard type papers and more recent patients of large volume centres. Now, we do take a caveat that we aimed for a sub and near total, whereas they aimed for gross total resection. We countered that with the fact we only had to reoperate on 1 of those patients. With some obvious limitations, we only had 43 patients to deal with. And some of the earlier patients, we didn't have electronic records from because it was pre the current system. And some of the more recent imaging we can't have due to the HC cyber attack. They're no longer on our system. So we have 2 cases to present, which I'll hand over to Oleksandra.
Okay, so I'm just going to present on the first case here. The first case is on patient CG, who is a 48-year-old female who presented to A&E with 3 witnessed generalized seizures, and she had falls and a headache for a week prior to presenting, but no previous seizures, and her past medical history includes a removal of a benign schwannoma ganglion on her hand 5 years prior. Her physical exam was normal, and she obtained a And she obtained a contrast CT brain, which showed multiple bilateral dural lesions. And on the right, we can see a mass protruding from the left internal auditory meatus, causing midline shift. And in both scans, you can see multiple masses along the meninges. So the patient underwent 3 surgeries, including left frontal craniotomy to remove the meningiomas and using the retrosigmoid approach to remove the vestibular schwannoma and meningioma. And the patient was subsequently diagnosed with neurofibromatosis type 1. This case emphasizes that although 90% of tumors in the CP angle are vestibular schwannomas, there can be other types of tumors present. Also, more than one type of tumor can be present, as was in this case, which requires multiple surgeries. It's also important to consider the patient's family, as with this patient, she had kids, and it is more for them to have genetic testing, as neurofibromatosis is an autosomal dominant condition. And this is the post-op scan showing good resection, and the patient has been doing well on follow-up. For case number 2, so TOG is a 55-year-old man who presented to his GP following feeling generally unwell with ataxia, mild hearing impairment, right facial numbness, weight loss, and anorexia, and past medical history includes hypertension. He obtained an MRI, which shows a large right cerebral pontine angle mass extending out of the internal auditory meatus and causing a midline shift. He underwent a retrosigmoid craniotomy for radical debulking and was well post-op with no injury to the facial nerve. Unfortunately, this man was lost to follow-up, and he represented 3 years later with dizziness, ataxia, and headaches. The MRI showed a large right partially cystic and partially solid mass that is causing severe brain concussion. He underwent a re-exploration surgery with a subtotal excision in the of the mass with the aim of preserving the facial nerve. Unfortunately, there was a post-op complication of facial nerve palsy and subsequent exposure keratopathy, for which he had temporary torsorrhaphy. And he also had a single fraction stereotactic radiosurgery. Patient is currently doing well. This case shows that despite vestibular schwannomas being benign and usually slow-growing tumors, it is important to be vigilant, and as they can sometimes follow a more aggressive disease process and cause lasting difficulties for the patient. Also, if he was not lost for follow-up and interval growth was identified, the mass was still small, he could have undergone stereotactic radiosurgery and have avoided the palsy.
Thank you. Thank you very much, Cathal and Oleksandra. I'm gonna, just for the sake of time, I'm gonna move on to the next, actually the previous talk. Vincent, I'm not sure if he's over his technical issues. Vincent? Very good.
There, yeah.
Now,
my computer didn't like the fact it was being recorded. It was a privacy thing, so all sorted. So thank you for this opportunity. This is a research project that came from Beaumont, the National Neurosurgery Centre, and looks at intramedullary ependymomas, specifically resection strategy, and whether or not that improves your gross total resection and your functional outcome in 3 months. So this was carried out under Professor Bulger's direction, and he's the PI. So just by way of introduction, this looks at grade 2 intramedullary ependymomas. These are circumscribed lesions, expansile, centrally located, and they have a very identifiable plane of cleavage. And this lends itself well to circumferential dissection to achieve a gross total resection, which is the focus of this study. So it's to look at whether or not removing the lesion en bloc versus piecemeal improves your outcome. The new WHO classification has changed things slightly in that there's no longer a grade 2 or a 3. There are simply spinal ependymomas or spinal ependymomas with MIC-N amplification. And this is a amplification that results in a much more aggressive aggressive pathology, and a much higher rate of recurrence. So grade 2 or 3 is gone unless you're using morphological grading, which is only if you cannot access genetic studies. So histological variants have been discontinued. So there's an established benefit in multiple papers to gross total resection, and this improves your overall and progression-free survival more so than subtotal resection with radiotherapy, which is next most beneficial, and then subtotal resection itself. So our aim is to compare en-bloc versus piecemeal resection strategies for these lesions in terms of your gross total resection rate and your functional outcome at 3 months. And functional outcome for intramedullary lesions typically uses the McCormick grading scale, which you can see below. And essentially breaking it down, the 1 to 3, you remain independent, and 4 and 5, you become dependent, and essentially grade 5, you lose all function. So quite in keeping with the name, en-bloc refers to resection of a tumor as a single mass via circumferential dissection around the lesion in a plane with healthy tissue. And so you don't disrupt the tumoral architecture, you don't enter the lesion itself, it comes out in a single piece. Whereas piecemeal refers to resection in 2 or more pieces, frequently via internal debulking, so intratumoral resection strategy, and that disrupts the tumoral architecture. And this is what we want to achieve with en-bloc. You see the picture there, a single sausage-like mass, which has been completely resected on the post-operative MRI. And this is a video. And so just orientation-wise, to the right is cranial, to the left is caudal. Laminectomies have been performed, the dura has been opened and hitched back with the white sutures, and then the pia itself has been hitched back. Sorry, the pia with the white sutures and the dura with the blue sutures. And you can see we're dissecting in that plane between tumor and healthy tissue, very carefully elevating the tumor and using patties to control bleeding. So this is a retrospective study finding 39 patients over a 13-year period, operated by 6 surgeons in Beaumont Hospital. Resection strategy was per surgeon preference, and an independent statistician was used. And just in terms of results, so from a demographics point of view, it matches published studies, which say the majority of these patients typically male, 2 to 1 male to female in our study. Average age is 46, again in keeping with the literature. A majority are cervical or thoracic, again in keeping with the literature. The average size are measured in levels of the tumors is 2.8 levels, and there's a 61% rate of having a syrinx. Mean symptom duration was 16 months, and we can see from the Venn diagram on the bottom right, the majority of patients will present with not just isolated pain, sensory or motor symptoms, but a combination of all, or 2. But pain will be present in 77% of patients, sensory in 70%. In terms of resection rates by strategy, so we can see, and we go into on the next slide, a higher gross total resection rate with the en-bloc group, so 86% in that first column there, as compared to a 52% gross total resection rate with the piecemeal group. And we have a 22 and 35% use of intraoperative monitoring for those in en-bloc versus piecemeal, which is not significant statistically. So this is the important slide. The critical finding of this is to say that en-bloc results the gross total resection rate.
You're breaking up
higher, and statistically higher than the piecemeal group. So 86% versus. And we performed a multivariate. So a multivariate regression analysis was performed to include multiple factors, and again, en-bloc and syrinx are the statistically significant factors, giving an increased odds ratio with en-bloc of gross total resection and a reduced odds ratio with syrinx present. It's important to say, if you do perform en-bloc, is it safe? Is it going to change your functional outcome? Is it going to be better or worse? So I suppose just to look at some of the numbers here, we see with the on-block it's in red, they're grade 4 and 5. So we see initial presentation of one patient who's grade 4 for the on-block group. And at 3 months then we have 13% or 3 patients who are grade 4, no grade 5s. Whereas in the piecemeal group, we had 1 patient who was grade 4 presentation, and that increased to 7 in the immediate post-op phase, and with some improvement to 4 patients being grade 4 or 5 by 3 months. So that's a 5.8% up to 23.5% increase in that group of disability. And we note that there's a new one patient with a new significant disability, which is grade 5. Another way to look at this is to say who has improved or deteriorated. And we looked at those, I suppose, first kind of far right to the improved group, the neutral group, the disimproved group, that's by 1 McCormick grade, and the double disimprovement, which is by 2 or more McCormick grades. And so looking at this, we can see the on-block group, the general trend is towards remaining neutral, or by a single point disimprovement, only 1 patient falling outside of that range. Whereas with the piecemeal group, it's much more varied, and there's a lot more significant disability. And again, we're running Fisher's exact test for this. It was significant. And just another way to look at this, again, I suppose just graphing it, the on-block being in yellow, the piecemeal being in blue, and then a pre-post and 3 months, kind of three tiers beside each other for first McCormick grade 1, 2, 3, 4, and 5. And we see the only new significant disability for grade 5 was from the piecemeal group. And I think there's an overall trend where people in the immediate post-op phase have improved by a grade by 3 months. So I suppose the other small points to make is that in other studies, presentation with motor symptoms has resulted or predicted a McCormick grade that will be lower post-op. This was not borne out by our results, it was not significant. And similarly, the length of the tumor was not significant. The approach significance was not ultimately significant for outcome. And the presence of a syrinx was not predictive of functional outcome, whereas it had been related to your gross total resection rate. So in summary, and to look at the numbers, on block increases your gross total resection rate. This is significant. And that's meant to be P 0.033. And the question is, why does this happen? I suppose we think it avoids missing fragments, and it also avoids seeding of tumor fragments, whereas piecemeal reduces your resection rate. And I suppose if you have a 50% gross total resection rate with the piecemeal group, that is obviously associated with a need for re-operation, rehospitalization, and a need for adjuvant therapies. And I suppose there is a financial cost to that as well. And there's also no evidence that the on-block group results in a worse neurological outcome. In fact, probably the opposite. It is more predictable with less new significant disability. And so in terms of multiple outcomes, we would strongly favor the on-block resection strategy. So that would be our conclusion, with some limitations, a single center at small numbers, and with no disclosures. I'd like to thank everyone involved, the consultants who've been involved, data collection, our research nurses, Paula Core and Deirdre Nolan. And I'm happy to take any questions.
Thanks, Vincent. That's very comprehensive. And I'm just going to ask you, but just quick question. You never mentioned the kind of taboo part of the ependymoma in Beaumont, neurophysiology, with or without?
So our rates for neurophysiology, 22% for on block and 23% for piecemeal. So we didn't have numbers to include it in the multivariate regression analysis. But I suppose the lead author, Professor Bulger, would have evidence from other papers to say that it does not improve your outcome. So I suppose we'll rest with that.
Okay, you can stop sharing. So just I can look at the questions if there are any other questions from the floor. Thanks a lot. Okay, while waiting for any further questions, I might just ask you the decision to go in block, and I understand the advantage and I understand the oncological advantage in addition to the other advantage that you just mentioned in this very comprehensive paper. The only problem with that is that you have to be committed to in-block based on radiological diagnosis, which I suppose is not that tricky, given that the other differential for intramedullary tumors is astrocytoma, which can differ radiologically from ependymoma. But my question is how comfortable you are, jumping into an in-block resection for something that you don't have a previous histological diagnosis.
Yeah, so I suppose 3 patients were also grade 2, but were not included in the study because they initially underwent biopsy followed by a resection strategy attempting, by piecemeal or en bloc costal resection. So I suppose that there is a cohort of patients in whom that is attempted. I suppose intraoperative findings of a good cleavage plane, if you're comfortable in making that call, I suppose with neuroradiology, that you're happy it is the ependymoma is available. I suppose there's no definite answer. It's probably okay. a decision and discussion with the surgeon and how comfortable they are with neuroradiology.
Thank you. We might maybe take the questions at the end of the session. I'm just going to move on to our last. This has been excellent, guys. Talks from Dublin, Beaumont, and Belfast, covering various subjects in this parallel session 2 and second day of Charter Day RCSI 2022. Great honor and pleasure to introduce the final speaker of today. It's a talk actually that's going to be presented by Mohammed Dablouk, who is SPR Neurosurgery here in Cork, but on behalf of both Mr. Mahmoud Kamil and Mr. Mohammed Habib Khan, both my very close colleagues and friends. Mr. Kamil is a consultant neurosurgeon with a very special interest in anterior skull base and pituitary surgery, and Mr. Mohammed Habib Khan, who is the ENT surgeon in South Infirmary Victoria Hospital here in Cork, who has a huge collaboration into the anterior skull base work. And Mohammed Dablouk is going to talk to us about establishing an endoscopic skull base service here in the south of Ireland, both audit and lesson learned. Dablouk, floor is yours.
Thank you very much. Good afternoon, everybody. It's great to be able to present to you today. As Mr. Mohammed said, I'm presenting on behalf of Mr. Kamal's service here in CUH. And we're going to be speaking a little bit about establishing an endoscopic transfemoidal surgery service here in Cork. First of all, I just want to thank Daniel and Mr. Khan and Mr. Kamal for their help with data collection and the presentation. So endoscopic endonasal transfemoidal surgery is a technique that has gained a lot of popularity in the last couple of decades. Compared to the more conventional transcranial approaches, it tends to be associated with a lower complication rate and a shorter inpatient stay, which has driven a lot of the enthusiasm in pursuing this approach. It's a very versatile approach and it can be used for a broad range of skull-based pathology, from lesions of the cribriform plate all the way to the pelvis, as you can see in the diagram here. The most common indication for its use is in dealing with pituitary tumors, and that's something that certainly applies in our centre as well. Pituitary surgery in general has come a long way over the last 150 years. From the late 19th century, where the first transcranial approaches were described by Dr. Horsley.
Mohammed, just if you can just improve the voice a little bit, maybe come closer to the mic. There's just a bit of noise when you're speaking. I'm not sure if it's just technical or. Just try again.
Just try again. Yeah.
Is this any better?
Much better. Thank you.
So the first transcranial approaches to pituitary lesions were described around 150 years ago, and the first transfemoidal approach was performed in the early 20th century, and many other attempts were trialed over the following number of decades. But the invention of the endoscope in the 1950s really revolutionized many areas of medicine, but especially or also including pituitary surgery. And the technique then developed over the following years up until the first kind of pure endoscopic endonasal transfemoidal approach was performed in 1995, and it's continued to develop since then. In CUH, we cover the catchment area of Munster, which covers a population of about 1.3 million people. And within our unit, endoscopic transfemoidal surgery is performed by one neurosurgeon. And we work very, very closely with endocrinology and with our colleagues from ENT, and Mr. Khan is involved in most, if not all, of our cases. This is our setup as it stands at the moment. So this is Theatre 1 in CUH, the neurosurgical theatre. You can see the patient comes in and they're positioned in the supine position. The kind of nasal area and the mid-face region are prepped, as you can see here, and Mr. Khan there is preparing to drape the patient. At the head of the bed, we've got our endoscopic stack, and just next to that, we have the neuronavigation system. And all these pieces of equipment help us to perform the surgery in a more safe and a more efficient manner. This is a photo of during the procedure. Again, you can see the endoscopic view and the neuronavigation set up next to that, and our scrub nurse in the background guarding the various different instruments that are used. And we use a lot of different specialized instruments with this approach. In terms of our pre-operative considerations, there's a few things we look at, and certainly regarding the approach, and it's very beneficial having the ENT surgeons available, because they give us a lot of insight with regards to the patient's nasal anatomy and things that we need to consider in that regard. And also the location of the internal carotid arteries obviously is of crucial importance when planning these procedures. And then with regards to the actual lesions that we're targeting, certainly for pituitary tumors, the NOSP grading is very important. That's illustrated in the diagram there on the right-hand side, and it relates really to how closely the lesion is related to the internal carotid artery. And it ranges from a NOSP grade 0, where the lesion is entirely separate from the carotid, all the way through to NOSP grade 4, which means complete encasement of the internal carotid artery. And the second thing, which is quite important, is to look at the extent rostrally of the lesion that you're going to tackle. And this varies. Sometimes we operate on microadenomas, which are confined purely to the sella, whereas on the other hand, you could have a very large lesion that extends into the floor of the third ventricle. And that's obviously a very important consideration in terms of your approach, and sometimes even the extent of bony removal, etc. Just some examples of some cases we've done over the last number of years. So on the left-hand side here, we've got a 44-year-old gentleman who presented to us with profoundly constricted visual fields and was found to have this very large pituitary adenoma, which we managed to treat successfully through this approach. On the right-hand side, a 72-year-old lady who presented with a nasoseptal chondrosarcoma, which was debulked using an endoscopic transsphenoidal approach. Here again, an 18-year-old girl who presented with a hypothalamic tumor with profound hormonal dysfunction, who had that lesion debulked by the same approach, and a 42-year-old patient with a large cavernous sinus schwannoma, which was excised, again, by the same approach. So what we hoped to do was to describe the current service provided in CUH and to identify some of the pathologies that we manage using this approach. We also wanted to look at some variations in the technique, such as lumbar drain use and the use of extended approaches. And we also wanted to look at our complications as well. So we did a retrospective chart review between January 2020 and November 2021. We included all patients undergoing endoscopic transsphenoidal surgery for mass lesions, and we excluded patients who were undergoing surgery for non-neoplastic pathology, so CSF fistulas, for example. They weren't included in the analysis. We identified 49 patients in whom 50 procedures were performed. These ranged in age from 16 to 84 years with a median age of 53. We had 23 females and 26 male patients, and the median length of stay for our patients was 5 days. 18% of patients were undergoing revision surgery. As expected, the vast majority of operations were performed for pituitary adenoma, so 80% in our series. 3 operations were undertaken for craniopharyngiomas. We had 2 Rathke's cleft cysts, and 1 each of chondrosarcoma, chordoma, metastasis, neuroepithelial tumor, and schwannoma. Looking at our pituitary patients, this is the breakdown of the NOSP grading. And obviously this affects how aggressive or how radical one can be with the debulking, but certainly our experience with non-functioning pituitary adenomas, which is the majority of the tumors that we deal with, the main indication for surgery tends to be visual deficit. And often in that case, we're not looking for a gross total resection, but more for debulking and to decompress the optic apparatus. We looked at some variations in surgical technique. So about 10% of patients underwent an extended transsphenoidal approach, and this was for lesions that were particularly challenging to access through a standard endonasal transsphenoidal approach. Lumbar drains weren't used very often up front. We used them in only 2 of our 50 operations, and this was to reasonable effect, as we'll see with our rates of CSF leaks later on in the slides. 8% of our patients experienced a nasal morbidity. 2 patients complained of nasal congestion, One patient had significant crusting that was quite bothersome in the first few weeks and months after the surgery, and one patient complained of an altered sense of smell. We only had one post-operative CSF leak that required a return to theatre, and happily we had no cases of meningitis or vascular injury. Looking specifically at endocrine complications then, what we found was that the vast majority of our patients really required hormonal replacement on an ongoing basis, so over 80%. And with regards to diabetes insipidus specifically, 4 patients developed permanent DI, whereas 5 patients developed transient diabetes insipidus that then resolved after a period of time. So from looking at our numbers, it seems that we perform about 2 transphenodal surgery procedures per 100,000 population per year. And from looking at the literature, the estimated incidence of pituitary adenomas is somewhere between 3.9 and 7.4 cases per 100,000. And naturally, we don't operate on all of these pituitary adenomas, so we feel that our volume is fairly appropriate given the population that we cover. Certainly, our rates of surgical complications are quite similar to what's quoted in the existing literature. And endocrine complications we found were more common. Certainly, transient DI occurred in 1 in 10 cases. And we had 8% of patients who developed permanent DI that required permanent DDAVP. And the majority of our patients required some form of hormone replacement. What we've established really from performing these procedures over the last number of years is that close collaboration with our ENT colleagues really is crucial. It's very helpful to have 2 brains working together, and certainly, we bring our set of expertise and the ENT surgeons bring their set of expertise to the table, and it's very valuable to have all that input when it comes to managing these complex patients. Our general workflow is that the exposure is led by the ENT surgeons, and the excision of the lesion then is led by neurosurgery. And when it comes to the skull-base reconstruction, which is a key part of these procedures, certainly there's very heavy involvement from both parts of the team. Some of the challenges and maybe lessons that we've faced and that we've learned over the last period of time, case selection is of utmost importance. And certainly that's something that can expand as one becomes more familiar with the technique. And acquiring instruments, and not only that, but teaching and training staff to be familiar and comfortable with those instruments is also something that is challenging. But again, as the service grows and we become more familiar with performing these operations, that's something that improves as well. In the future, some things that would be of benefit, we'd like to have detailed pre-operative and post-operative assessments of the patient's endocrine status. That's something that would really be helpful to have, and probably something we need to do on a prospective basis, because many of our patients are transferred in from other units, and sometimes their endocrine follow-up is performed in another hospital, and we may not have easy access to those notes. Similarly, with visual outcomes, the pre- and post-operative formal ophthalmology assessment may be performed in a different institution, and it would be very helpful to be able to collect that information on a prospective basis to be able to formally evaluate our outcomes that way. We'd like to be able to report on nasal complications in a little bit more detail. It's something that's been explored in the literature to some degree, but something that we could report on in a little bit more formal fashion. And the final point we'd like to look at is our skull-base repair techniques and the rates of CSF leak that we encounter. And certainly we've been quite satisfied with our rates up until now. But again, it's an area where there can always be improvement, and something that we hope to look into in the future. Thanks for your attention. I'll take any questions.
Thanks, Mohammed. Excellent talk, and it's very reassuring and inject us with joy to see the numbers are comparable to other centres, and that tells how much both Mr. Kamal and Mr. Khan have raised the bar of establishing this service here. A shout out obviously to their predecessor, Mr. George Carr, who retired, who used to do most of the pituitary work here solo. But I assume we have moved considerably in the right direction in the last 3 years. Any questions? The guys in the attendee can type their questions and we can answer them. If there's any person in the panelists wants to ask questions, then feel free to do so. You just need to unmute yourself. I might just ask you a question, Mohammed. This is maybe not related directly. How do you feel as a trainee when there are two surgeons in the room? Do you think it's eating a little bit from your share, or do you feel that it's still beneficial?
To be honest, I think my experience has been more on the contrary. I think it's a great opportunity to learn from somebody who's coming from maybe a slightly different perspective to what we're used to dealing with. And I think I've learned just from working with Mr. Kamal over a period of months and from experiencing these cases with input from ENT, I've learned so much about nasal anatomy and how to kind of deal with the nasal anatomy and more about skull-based anatomy as well. So I think as a trainee, it's more of a benefit, if anything, rather than a hindrance.
Okay, very good. Any other questions? So I have a question here. Why is it not coming up on the... So I have a question here. What is your opinion on the endoscopic transorbital approach to access cavernous sinus lateral compartment? Is it a technique that is going to be used more in the future? I presume this is not probably directly to the talk, but do you have any thoughts on this, Mohammed?
Yeah, I suppose certainly it's not something that it's not an approach we've used here, but obviously we'd be somewhat familiar with it from seeing presentations about it and grand round discussions about it, but particularly from people in maybe mainland Europe and the States. I think certainly as it becomes more prevalent, maybe we find more indications to use it, but I think the ideal obviously is finding opportunities for maybe as trainees going to some of these centers and seeing these operations being performed and maybe trying to get a sense of what the indications would be, and maybe bringing some of that back and trying to develop the service here if it's something that would be beneficial in the future.
Thank you. Yeah, I think I agree. I agree with that. We probably have one more. We have time for one more question if possible. I might have a bit of delay between the questions being asked and appearing on my screen. Any of the panelists want to add anything? Any final remarks? Okay. We all happy? So guys, this has been great. We had various talks from all three Irish centres, Belfast, Dublin and Cork. We've heard Tom Flannery talking about his experience in low-grade glioma, and we learned obviously that the move towards more resection rather than watch and wait is evident to have benefit in overall survival. We've heard from Vincent about the intramedullary spinal cord tumours and the benefit of in-block resection. We've also heard from Michael O'Sullivan and his team, Cathal Lee, about their experience in vestibular schwannoma and the comparable figures, despite the fact that Cork is kind of smaller unit to the bigger centres. We also heard from Mohammed Dablouk about the establishment of the anterior skull base service here in the south of Ireland. And we've heard from Michael Amoo about the Dublin score for chronic subdural hematoma, predicting the recurrence of chronic subdural hematoma patients. That has been an amazing day, and I'm thrilled to have chaired this session. We will conclude this now, and thank you very much for everybody who attended. All the panelists, thanks a lot for your presentations, and all the attendees for being with us today. Thank you and goodbye.